concerns? Next steps? Do we have a strategic plan for social mission? A national strategic plan? You know, in higher ed, I'm always thinking, you know, we have a strategic plan for everything that we do. Where's the strategic plan in our country to eliminate healthcare disparities? Question.
Hi there. Can you hear me? Okay. Well, thank you, first of all, for your provocative and thoughtful comments and for honoring Fitz. I wanted to ask a question about what do you say to your colleagues who too often do blame the patient? Say, you know, I don't judge my patient for not following their diet or for smoking. I don't judge my patient for all what we know are structural determinants of health. But there's also an internal recognition of an incentive system that sets them up to benefit from the disparities, that they're in practice because of the disparities. So I'm curious, what do you say to the providers that you work with around how to manage that tension of the perverse incentives, that even those who are there to do good also fall trapped to in making their own way in their lives? How do you manage those complexities?
Can you just repeat what you said about the tension? I'm not getting it, like someone's benefiting, I thought I heard?
Yeah, exactly. So working with healthcare providers who are looking at bias and who are on the journey, but nowhere near where we'd like them to be, who recognize that they benefit from the structural inequities, from the disparities, and that they don't judge patients due to, quote unquote, individual choice, individual rights. I'm there to care for the patient. I'm not there to judge what they do, how they live their life, which we also know patients are set up to make certain choices due to structural racism, due to disparities. And they recognize behind closed doors, or sometimes overtly, that they benefit, that they send their kids to school because they have a job, because their patients are making quote unquote poor choices, placing the blame with the patient rather than the systems. And I'm just wondering, when you're working with providers to have an awakening, to understand that they're managing that tension in their day-to-day, what do you say to them?
Great question, now that I know what you're asking. So what do you say to your colleagues when it sounds like they have a privilege and they don't realize it? What do you say? Well, for me, I can't change one's reality. I can argue reality, but for what, right? You have to realize that narratives play an important part of the discourse, but at the end of the day, you cannot change what another person is thinking. However, you can help change policies that control for who comes into the health professions. If we have individuals in the health professions who outright discriminate towards a patient, I'm asking, how do the policies allow this to happen? Because we're going to have individuals that think certain things. You'll have individuals that disagree. That's okay. We don't want a reenactment of the Stepford Wives, if anyone remembers that show, right? We want people to be able to think, right? That's the best thing about diversity, having different ideas. But at the end of the day, our mission, our principles, our values as a healthcare discipline, that has to be our North Star. So I encourage colleagues to argue with me, argue points with me. That's the whole purpose of diversity. We want different thoughts, different minds, different perspectives, people from different backgrounds and experiences, because the experiences shape the lens through which we see and navigate life. So when a person doesn't say something that I agree with, okay. But we have to, at the end of the day, agree on certain things. Our mission, our professional values and how they get operationalized, and the accountability when we violate them. And sometimes that accountability is not there. Great question. Yes?
Thank you, Dr. Beard. I just want to say, you know, what we're asking of our faculty, staff, and students and our healthcare providers is a really heavy lift. And the reason why I say that is because this puts them in very vulnerable spaces, particularly our faculty, you know, when they're in institutions and students are coming to them and saying, you know, Dr. Perry, you know, this is happening, or Dr. Jones, can you help me? You know, and as a faculty member, you're trying to assist these students, or you're trying to help your colleagues, and you're in an environment that's very vulnerable. People are trying today to keep a roof over their head and food in their mouth and send their kids to school, and the thought is if they take up this issue of social injustice or trying to right wrongs, you know, will it be worth it for them? And so I was hoping you could speak about that, because you talked about fixing the system. And it's, you know, it's a multifactorial fix. You know, we have to look at accrediting bodies. We have to look at licensure, you know, continuing education for our professionals, and just changing behaviors. You know, I listened to your presentation, and it just reminds me of the oral health gap. You know, I just recently moved here to Arizona, and what I was shocked to find is that underserved and vulnerable white, African American, and Hispanic and Native American populations, they don't have access to comprehensive oral health care. And it just reminds me, maybe that gap is too deep, as you said. Is it too costly, you know, here in Arizona and some of the other states to provide that? You know, we took a task force to the state capitol to advocate for them, and we walked away again without oral health care, comprehensive oral health care for vulnerable and underserved white, Hispanic, African American, and Native American populations. So I guess the gap is still too deep, and it's too costly here in Arizona as in other states, but hopefully we'll go back in 2023, in 2024, and 2025, and again, until someone values this patient population. So I just wanted to say that that space is very vulnerable for people who have to say, I'm willing to do something to help, particularly if you're a faculty member or you're an administrator.
Well said. Thank you.
Hi, good morning. Thank you so much. That was an amazing, that was really amazing, so thank you so much for your words. I wanted to just build on that idea of vulnerability, and you mentioned earlier when the example with your son, that you're not usually the ones to take to social media and not usually the one who's going to shame and blame. And I was wondering if you could elaborate a little bit more on that and the idea of sort of choosing our battles and thinking about like when to go out there and how hard to go out there and how you kind of factor in various issues that might come to play when making those types of decisions.
Oh, great question. So yes, I don't believe that any of us should shame anyone, because who here has not said something or done something that they've regretted and wish they could take back? I mean, I don't think you could say that you've never done that. And if there's anyone here, please stand up, write a book, it'll be a bestseller, because we're human, right? Sometimes we say things that we should not have. And that humanism piece has to come in. You have to be able to see how you too have screwed up, and how your colleagues have had mercy, and someone has helped you through it. So no, I mean, yeah, we sometimes do some horrible things. We can look online just from Monday night with Will Smith and Chris Rock, right? And you see all the chatter. It's not that we should not be held accountable, but we have to realize that sometimes we make associations based on experiences. So if you have a colleague who was abused, physically abused by a partner, Her reality about what happened with Will Smith and Chris Rock is going to be totally different. And you might hear your colleague saying, throw the book at him, because she is speaking from her past experiences. And that's how most of us respond to things, and sometimes we don't even realize we're doing it. We respond based on past experiences, and then it comes to the forefront, and we're trying to address something, but we have to take a break, take a step back and pause and understand, at the end of the day, we are all human, we will all make mistakes. We are in a healthcare profession where we are trying to make a difference, which means that we do have to be vulnerable, we have to be humble, and are we providing opportunities for our students to do that? Are we demonstrating that in the classroom? Do we show our humility or vulnerability? Or do we walk around making students believe that we're beyond reproach, that we're just perfect, that we woke up with this knowledge? We have to be real. And sometimes it's hard for some people to be real.
Thank you, Dr. Beard. We have one last question from a virtual attendee. And that question, first they say, this has been a great talk. How do you start discussions with fellow faculty who do not want to look at their teaching materials for racism?
Do we have another hour? So another great question. So what do you do when your colleagues say, I'm not looking at this information? You can't force them, right? And you can't be like Will Smith and just go up to someone and smack them. No, that's not what you do, right? That's anger mismanagement. Kubler-Ross said we could all be angry, but how you demonstrate your anger. So some of us, we get angry, we write, we publish. We let people know what's happening. We try to make a difference. But you need to be on the right committees at your institution so that there are policies in place. Because whenever I have a colleague who says, this is not happening, I ask, show me the policy where it says it's supposed to happen. Because we do what the policy tells us to do. And when we don't do it, we have something to hold people accountable to. So it's not a matter of what Kenya says you should be doing. Am I at the right institution? Because the right institution, I've learned after all of my relocations, you find an institution and you ask those powerful questions. Who is saying that this has to be done? Where is it? Is it in our strategic plan? Is it in our mission and our values? Is it in our goals, our annual goals? Do you expect me to do something about health disparities in my annual goal? Because if you're not really asking these questions, and it's nowhere in your policies, and there's no way to hold a person accountable to this, then sometimes it's just not going to get done.
Sorry. Hi, Kenya. I'm Julie Orban. I work on the Social Mission Metrics Initiative. And I think you mentioned about the strategic planning of social mission nationally. We are working on that at the Beyond Flexner Alliance within GW. Some of the focus areas that we've noticed is that we need to focus on students, getting students involved in social mission. We've also noticed that the terminology of social mission hasn't been publicly recognized as well. So we're working on a media campaign for social mission. We also recognize that we need to reach higher in terms of policy and accreditation standards. We've conducted a social mission, a review of accreditation standards of health professions education, and have found that there are variances in the terminology and use within accreditation standards. We also recognize within accreditation standards that racism and race isn't recognized. So there are various moving parts currently, but I think with all of us here, I think it's very important that within our own institutions that we elevate the conversation about social mission and continuously use the term social mission. For example, in the Future of Nursing report, there is no mention of social mission. They utilize some of our research, but they used terminologies like diversity, right? Diversity in training within the nursing workforce, but social mission isn't explicitly used. So I think the conversation here is to broaden the public awareness around social mission within the institution as well in the broader community. Thank you. Thank you for your presentation.
Thank you.